Hey, BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic, NSAIDs and kidney disease. NSAIDs are known to be nephrotoxic, but the thing about NSAIDs is this: they work. When I have acute pain, I'm reaching for NSAIDs. I take them, while at the same time, I advise many of my patients with kidney disease to avoid them. So what gives? I recently was asked at what stage of kidney disease, at what GFR, are the use of NSAIDs an absolute no-no? I didn't have a clear answer to this question, so I researched the data, sought some expert opinions, and here's what I've come up with. We're going to talk about NSAIDs in the relationship to acute kidney injury, proteinuria and the nephrotic syndrome, chronic kidney disease, electrolyte disorders, particularly hyperkalemia, as well as hypertension and fluid retention. So let's get into it. How do NSAIDs work? NSAIDs work by inhibiting cyclooxygenase, and cyclooxygenase is involved in the production of prostaglandins. And in the kidney, both non-selective NSAIDs and selective COX-2 inhibitors affect the production of renal prostaglandins. So many, if not all, of the potential adverse renal effects of NSAIDs come from decreased renal prostaglandins. First, acute kidney injury. The most common acute kidney injury caused by NSAIDs is a hemodynamic acute kidney injury related to decreased glomerular perfusion. Prostaglandins work to dilate the afferent arteriole, which goes into the glomerulus. For most people, this dilatation of the afferent arteriole mediated by prostaglandins is not necessary, and NSAIDs don't cause acute kidney injury. However, there are some situations where the kidney, the glomerular perfusion pressure, and the GFR is dependent on this prostaglandin-mediated afferent arterial dilatation. These include hypovolemia, states with decreased effective arterial volume. These are edematous states with their spacing, such as cirrhosis and congestive heart failure, as well as when the other compensatory mechanism, constriction of the efferent arteriole, is impaired. This typically is intentional with medications such as ACE inhibitors and angiotensin receptor blockers. Now, most cases of hemodynamically mediated acute kidney injury by NSAIDs are functional. That is, when you stop the NSAID, the GFR quickly returns to its baseline. However, if the decrease in perfusion pressure is severe enough and prolonged enough, ischemic ATN can occur. Next, NSAIDs, like many drugs, can cause interstitial nephritis. The interstitial nephritis caused by NSAIDs is somewhat unique. It is associated with an elevated creatinine and an interstitial infiltrate on kidney biopsy, like most interstitial nephritis. However, there is more severe proteinuria. And renal pathology often shows a minimal change picture with a normal looking glomerulus on light microscopy and diffuse foot process effacement on electron microscopy. NSAIDs can also cause proteinuria and the nephrotic syndrome without interstitial nephritis, either by a minimal change lesion or also by a secondary membranous nephropathy with subepithelial deposits on electron microscopy. Now moving to chronic kidney disease. It's patients with chronic kidney disease who are typically advising to not take NSAIDs. There's really not much data to invoke NSAIDs as a cause of chronic kidney disease or a cause of more rapid progression of chronic kidney disease. There is a condition called analgesic nephropathy that was seen more commonly in the past and is seen very rarely, if at all, presently. Analgesic nephropathy is a cause of chronic kidney disease with characteristic renal papillary necrosis with calcifications. This was with patients who had prolonged use of multiple analgesics, typically in combination. One of the analgesics that was commonly involved was something called phenacetin. Phenacetin was removed from the market many years ago by the FDA because of this association, and analgesic nephropathy is rarely, if ever, seen currently. What about the progression of chronic kidney disease? I've not been able to find much data to invoke NSAIDs in this as well. It is true that patients with chronic kidney disease who take NSAIDs and have the NSAIDs withdrawn often have a significant increase in GFR, and this increase in GFR is more prominent the more severe the chronic kidney disease. For example, one study showed that patients with stage 5 chronic kidney disease, the average GFR increased from 12 to 26 upon discontinuation. However, I've not been able to find much evidence that NSAID use increases the rate of GFR decline. The bottom line is that chronic kidney disease is a risk factor for NSAID-induced acute kidney injury, and in these patients with decreased renal reserve, having acute kidney injury, especially recurrent, repeated episodes of acute kidney injury, can be associated with progression of chronic kidney disease, and is typically something that should be avoided. Moving on to electrolyte disorders, prostaglandins also increase renin production in the kidneys. So when this process is impaired, there can be a propensity toward hyperkalemia as the renin-angiotensin-aldosterone axis is adversely affected. For most people, this is not an issue, but for people with other factors that impair the renin-angiotensin system, most commonly medications such as renin-angiotensin system blockers or mineralocorticoid antagonists, diabetes, or chronic kidney disease may be at increased risk for hyperkalemia. NSAIDs also can cause hyponatremia as prostaglandin impairs the effective antidiuretic hormone. Finally, prostaglandins contribute to renal sodium excretion, natriuresis, so impairment of this can lead to hypertension and fluid retention edema. So what's the bottom line? In my mind, patients with more advanced chronic kidney disease, stage 4 and stage 5, the use of NSAIDs is generally not a good idea. Likewise, it is not a good idea to use NSAIDs in patients with a propensity toward hyperkalemia from medications or other conditions. If NSAIDs cannot be avoided, if there is no alternative or the potential adverse effects of the alternative is worse, make every effort to use the lowest dose, and for acute pain for the shortest period of time, less than 1 week. For both acute and chronic pain, if needed, would reserve NSAIDs for the breakthrough, more severe pain and try to use other measures for the less severe baseline pain, and give consideration to holding other medications that may affect renal function or cause hyperkalemia, specifically renin-angiotensin system blockers and mineralocorticoid antagonists. Also, in patients who present with nephrotic syndrome or hypertension who take NSAIDs chronically, it is reasonable to try to withdraw this medication to see if the condition resolves spontaneously before deciding to treat with other medications. So that's it. Thanks for watching. If you made it this far, you might as well hit like and subscribe. Leave a comment. What is your experience? What do you think about NSAIDs and kidney disease? Until next time.